Uh, Good evening, everyone. So, as a part of our series of integrated medicine, today we will discuss three clinical cases of hepatobiliary system. So, starting with the first clinical case, so it will be an integration of medicine and surgery. I will be discussing some of these cases. I will be taking the medical aspect, and Dr. Tewari will be taking the surgical aspect. So, starting with the clinical case number one. So, 24-year-old female. So, age is 24-year-old. 24-year-old female presented with 5 days history of yellow eyes. So you can see the presentation is somewhat acute here. Yellow eyes, right upper quadrant discomfort, and general sense of fatigue. Stools were of normal color. That means stools were not pale in color. Her usual alcohol intake 2 drinks per week, and she used no medications, over-the-counter medications or NSAIDs, no nutrition supplements or herbal medicines, and no drug abuse. There is no history of previous blood transfusion, contact with the hepatitis patient, and she had no tattoos. She had unprotected intercourse 8 months back previously, and there is no significant family history. So these are the clinical information available with us, and based on this clinical information, only from the history basis, I can make my diagnosis as a case of a jaundice. This is a case of a jaundice, and this jaundice is most likely hepatic jaundice because stools were normal color, and there is no pale color stool, there is no itching pruritus, which is suggestive of the obstructive feature. So here jaundice is present, and we can, on the basis of history, we can just rule out the obstruction feature are not present in our patient. And other history ki whether this jaundice etiology is drug induced or a viral hepatitis or other autoimmune hepatitis. So these are being given here, that there is no history of any drug intake, there is no history of previous blood transfusions, and there is no significant family history in our patient. So first we have make a diagnosis of acute hepatitis in our patient or acute jaundice in our patient. So provisional diagnosis, this is acute hepatitis. In this patient, when we examine the patient, she was clinically well, hemodynamically stable, there was no fever, but jaundice was there without any lymphadenopathy, peripheral edema, or any finger clubbing. There are no signs of chronic liver disease in our patient or any portal hypertension in our patient. She had a liver palpable 3 cm below the costal margin. That means there was some sort of a hepatomegaly was there, and it was non-tender hepatomegaly. Cardiac and respiratory examination was unremarkable. From the examination, we have come to the conclusion that it is acute hepatitis, and hepatomegaly was present. It was palpable. Now, in this patient, investigations were done, and investigation showed that hemogram was normal, prothrombin time was okay, but the liver enzyme, the most important thing that you will look at the liver function test, the liver enzymes were elevated. ALT is 858, ALP is within the normal range, so ALP is normal, ALT is grossly elevated, which further support our diagnosis that it is not obstructive jaundice. Albumin is okay, that means it is not a chronic liver disease yet. Ultrasound scan of the abdomen shows a mild splenomegaly, no gallbladder stones, and liver was homogeneous and of normal size on the ultrasound. So these are the information available with us. So what if we summarize the information? Patient was provisionally diagnosed as a case of a acute hepatitis with raised ALT enzyme. This is the provisional diagnosis. Now, my question to you is, what is the clinical problem and what is the differential diagnosis in this case? Clinical problem we have already done. This is a case of a hepatitis. It is a case of a hepatitis. And what is the differential diagnosis in our case? The differential diagnosis of this hepatitis, which is most likely a acute hepatitis. It can be a viral hepatitis. It can be a toxin-induced hepatitis, or it can be some hepatitis which initially present as acute, later on if it is not treated can convert into chronic hepatitis as well. So it can be autoimmune hepatitis. Maybe the first episode of autoimmune hepatitis we can keep a possibility, the first episode of autoimmune hepatitis. So these are our differential diagnosis. So what further investigation should be done in this patient? So obviously we have to make a etiological diagnosis of these conditions. We will have to go for a viral markers in our patient, mandatory. Patient presented with acute viral hepatitis. Toxin is a less likely cause because the alcohol intake was not that it causes a alcoholic hepatitis, or there was no drug abuse, no herbal medications were being taken. So this is unlikely. This is unlikely. So we will go for the further investigation which should be done in this case will be the serological markers. So read the serological markers very carefully. Hepatitis A IgM was negative. Hepatitis B surface antigen was negative. Anti-SCV was negative. And hepatitis E IgM was negative. That means that most of the viral hepatitis serology are negative in our patient. So it is unlikely the viral hepatitis. So viral cause is not there. While the other markers that we do is the autoimmune marker. ENA is positive in our patient. ENA is positive. Anti-mitochondrial antibody is negative. So that means the primary biliary cirrhosis or cholangitis is unlikely in our patient. And remarkably, IgG antibody were elevated. So when viral marker are negative and the auto antibodies are positive, so this should strike in your mind that it could be a case of a autoimmune hepatitis. So this provisionally we can make a case of diagnosis now is autoimmune hepatitis. Provisional diagnosis. So next question. We have made what is the most likely diagnosis? It is a autoimmune hepatitis. So question is, so this will be a sequence question. Like a clinical patient present, you have made a clinical diagnosis, which basic investigation were done, and on the basis of this investigation, what is your provisional diagnosis and what can you do to prove your diagnosis, a confirmatory test. So what will be your next line of the investigation if you are suspecting a autoimmune hepatitis? So answer is, to prove the autoimmune hepatitis, our next line of investigation will be a liver biopsy. Yes, it will be a liver biopsy. And what will be the finding in the liver biopsy which will prove our diagnosis? It will be the plasma cell infiltrations. So that will almost confirm our diagnosis of the autoimmune hepatitis. So this is how to approach a clinical case coming to you with acute hepatitis like picture. Now finally, how will you treat this patient? What will be the treatment of this patient? The treatment of choice or drug of choice, all of you know, it is the steroids. Drug of choice, steroids. You can plus minus add azathioprine. Most of the hepatologists, they give azathioprine simultaneously with the steroids. Now, Patient you have recommended, you have prescribed that steroid should be given to our patient, the drug of choice. But unfortunately, patient didn't take the steroids. This female didn't take the steroids as prescribed because she read the side effect of the steroid on the internet, that it causes a black fungus which can invade the eyes and the brain. So after reading on the internet, a typical patient of a WhatsApp university and social media university, so she didn't take the steroid, and after 2 years she returned back with cirrhosis of the liver. Unfortunately, autoimmune hepatitis is one condition which very well respond to the steroid therapy, and cirrhosis can be prevented. But she was non-compliant, so she presented with cirrhosis of liver. So what will be our next line of management in cases of autoimmune hepatitis with established cirrhosis? Obviously, at this stage, steroids will not work. Steroids will not work. So the disease which could have been prevented to convert into the cirrhosis, now patient landed up into cirrhosis. So the next line of treatment in this case will be liver transplant. So I will hand over to Dr. Tewari for some points on the liver transplantation.
Thank you, Dr. Arvind, and good evening to all of you. I'll just discuss the salient features of liver transplant. We don't have time to discuss the complete liver transplant, but the questions that are frequently asked from liver transplant. Next slide, please. Yeah. So you see 3 criteria, another 4 criteria, all of you. Obviously, fibroscan is important. Projecta, you are absolutely right. That's the medical part. Coming to surgical part, 3-4 criteria. All of you should remember, you have MCQs on those. One is child's book, second is MELD score, third is PELD score, and fourth is Milan criteria. All 4 have different indications and different use. Child's Turcotte book, I am sure you must have read in medicine, and I'll request all of you to remember rest 3. I'll not advise you to remember the formula or the values, but child's book you have to remember with values. Very often I see question from child's book score. And don't get confused, there was a criteria just child's score, no book, no Turcotte. That was the 30-40-year-old criteria. The 5 parameters in child's criteria were nutritional status, ascites, albumin, bilirubin, and neurological status. What happened that nutritional status was replaced by prothrombin time, and it became child's book. So the difference between child's and child's book is that in child's book, rather than nutritional status, you have prothrombin time. And now we are using INR, so it has become child's book Turcotte. So this formula, I'm sure you'll find in all medicine books, surgery book. Please memorize. We have score from 5 to 15, 5, 6 is A, 7, 8, 9 is B, and 10 onwards is child C. Child C means mortality within 1 year is 50%, and that is the patient whom we consider for transplant. Next slide, please. Next, yeah. So MELD score, don't see this slide and formula. You need not memorize the formula. You only have to memorize 3-4 lines about MELD score. MELD stands for Model for End-Stage Liver Disease. This formula was devised by Dr. Patrick Kamath. As the name suggests, Kamath, he was from India. He is rather from India, though he has settled in Mayo College in England. He did his education from Bangalore and AIIMS and PGI. Finally shifted. He's a professor in Mayo College, and he devised this formula, Patrick Kamath. So the question they ask is, what parameters are used in MELD score? And if you read the first line, the heading, it includes bilirubin, INR, and creatinine. The first line at the top, and creatinine. And after 2016, they have added sodium also in this. So we have bilirubin, INR, creatinine, and sodium. These four we consider, we take 4 parameters. And there are certain rules that you follow, like creatinine less than 1, you give 1 mark. Patient is on dialysis, you directly put 4, creatinine 4. Next slide, please. Yeah, so you'll find many softwares, even online software, you just have to put the value and you get the score. The score ranges from 5, we say 40, the score can be more than 40. But the mortality at 40 is around 70 to 80%, and same mortality is when the score is even more than 40. So whether I write 40 or 50 doesn't matter, the mortality is same, so we have kept the highest score as 40. Higher the score, poorer is the prognosis. Next slide please. So remember, bilirubin, creatinine, INR and sodium. These 4 parameters you have to take. Next slide please. These lines are not important, only last 2 lines you have to remember. If the MELD score is more than 19, the last line in blue color, you refer for transplant. And more than 25, then the transplant should be done on urgent basis. Then you have to do MELD score weekly. Next slide please. Now MELD score is a pediatric score, and the figure, the 4 lines shown with blue arrow, what MELD score includes? Albumin, bilirubin, INR, growth failure and age. Only remember the parameter, no need to memorize the value or the formula. The question they ask is what parameters are included and what is not included. If you see the right half of the slide, urea cycle disorder, organic acidemia and hepatoblastoma, these are exceptions of MELD score. Here directly you give 30. MELD score will be 30 if patient is suffering from these conditions. Next slide please. Yeah, Milan criteria, I think it has been asked 2 or 3 times. Milan criteria is not for any liver transplant like for cirrhosis. It is only for hepatocellular cancer. Liver secondaries is a contraindication for transplant, but primary is not a contraindication. Someone having HCC, still you can do transplant if these criteria are fulfilled. And remember, it is only for HCC patient, not for any patient. So Milan criteria is for transplant for HCC, and it includes if there is a single tumor, it should be less than 5 centimeter. Multiple tumor should be less than 3 number and less than 3 centimeter in size. No major vascular invasion, no extra hepatic involvement. If these 4 criteria are fulfilled, then this is Milan criteria, given in 1996 by Mazzaferro, also called Mazzaferro criteria. But in MCQs and book, they only say Milan criteria. We do have some more criteria for cancer, for transplant, like UCSF, University of California, San Francisco, etc. Not important for you, only remember Milan. Next slide, please. Now the incision you give, you can see the incision we make is a reverse T kind of incision. For Whipple's operation, for pancreas, we give an inverted V-shaped incision called rooftop or chevron, CHEVERON. Here we give an inverted T-shaped incision. Next slide. And this is what you do. This is a cadaver transplant where the whole liver is taken in toto with a part of inferior vena cava. And you can see you have simply done anastomosis end to end. Inferior vena cava with inferior vena cava, portal vein with portal vein, hepatic artery, and bile duct with bile duct. Next, the downward arrow. Yeah, so you can see the arrow, blue arrows, showing simple anastomosis. Next slide, please. Next one. Yeah. So here you can see just anastomosing vena cava to vena cava, hepatic artery, portal vein, bile duct. Now there's a problem. Next slide, please. When we cut vena cava, then you have to do, liver transplant is a orthotopic. Orthotopic means you take the liver out and put a new liver at its normal position. If I put the organ at a new position, different position, then we call it a heterotopic transplant, like kidney and pancreas. Kidney and pancreas are placed in the pelvis, while liver, heart are orthotopic. वहीं लगाते हैं जहां से निकालते हैं. So you can see here in the first diagram, we have done cross-damping of vena cava, but the blood has to be in circulation. Infradiaphragmatic blood has to go to supradiaphragmatic part. So in the second diagram, you can see we have done a veno-venous bypass. Suppose I don't want to do veno-venous bypass. I don't want to put the patient on a machine. I don't want to cut the vena cava. Then we have a technique called piggyback technique. Next slide, please. This is a important point in liver transplant. This is what we do very often. In cadaver, we are not cutting the vena cava and not anastomosing the vena cava to vena cava end to end. You can see 3 hepatic veins shown by blue arrow in the lower diagram. You can cut the in-between wall and make one trunk and anastomose vena cava to hepatic vein of the recipient. So this is a piggyback technique. Please, next slide, please. Next slide. Yeah, so here you see, in first diagram, I am doing a side to, this is a Setinsky clamp applied. This is a vascular clamp which you see on the vena cava, Setinsky. So in first slide, it is side to side anastomosis, while in the second diagram, the right one, blue arrow is showing that vena cava is anastomosed to chunk of hepatic vein. We are not anastomosing vena cava to vena cava, rather to the hepatic vein. Next slide, please. Next, yeah. So here also you see the vena cava of the donor is anastomosed to the hepatic vein of the recipient. So I need not cut the vena cava and I need not do veno-venous bypass. We are not cutting and ligating the vena cava. Next slide. Now this diagram is showing the difference between the two. First one is a cadaver transplant where you cut the vena cava, and it is obviously cadaver because I cannot take the whole liver from a live person. Live person transplant will always be a split liver transplant. You will only take a part of liver. So here you can see the first diagram A, vena cava anastomosed to vena cava, end to end, while in B, it is a piggyback technique, which is MCQ. Next slide. Now this is a split liver transplant, which is a part of the liver we are using only. The first renal transplant was done by Joseph Murray in 1954, and he got Nobel Prize in 1980 for his work. First liver transplant was done by Starls, S-T-A-R-L-Z, Starls. Heart transplant was done by Christian Bernard. Pancreatic transplant was done by Lillehi. While split liver transplant, what you see in the diagram, that part of liver I am taking, that was done by Pickle-Meyer, P-I-C-H-L-M-A-Y-R, Pickle-Meyer. So this is a split liver transplant where I am only taking part of liver. For survival, we only need 1/3, 30% liver. 2/3 liver regenerates in 6 months' time. So 3 liver segment, what you see in the lower part of the diagram. First is the right lobe, 5, 6, 7, 8 segment. Second is the left lobe, 2, 3, 4 segment. I'm sure you must be aware of the liver anatomy. And the last one is only left lateral hepatectomy, that is segment 2 and 3. Normally, we do either left lobe or left lateral. More often, we do left lateral, only segment 2 and 3. This left lateral is anatomical left lobe. Surgically, it's only part of left lobe, segment 2, 3. Next slide. Yeah, so this is a diagram of split liver transplant. Here, I'll emphasize one more point. You see, I told you that bile duct is anastomosed to bile duct, hepatic artery to hepatic artery, and portal vein to portal vein. But when end to end. But when we do split liver transplant, then we don't anastomose bile duct to bile duct. Then we do Roux and Y hepatico-jejunastic. So in cadaver transplant, we can anastomose bile duct to bile duct. But in live donor transplant or split liver transplant, the bile duct is not anastomosed to the recipient bile duct, rather it is anastomosed to jejunum after making a Roux and Y. R-O-U-X-E-N-Y. We write it Roux and Y, but we pronounce it Roux and Y. So this is a split liver. Next slide, please. Yeah, so this is again split liver transplant. Next slide. There was a question on auxiliary liver transplant. The question in all India was only one question. What is the main indication of auxiliary liver transplant? So what is auxiliary liver transplant? In normal liver transplant, we remove the native liver and put new liver in place of original place. While in auxiliary, we leave the liver and place either a part of liver or new liver by the side of it. It's a heterotrophic transplant. So in the second diagram, you can see on the first diagram also that another liver is placed, leaving the native liver behind. So this is generally done. Either you expect liver to regenerate after a few months, or patient condition is very sick, like fulminant liver necrosis. So the question was, what is the most common indication of auxiliary liver transplant? The answer was fulminant hepatic necrosis. Okay? So auxiliary liver transplant is a kind of heterotrophic transplant where we don't remove the liver, put a new liver by side of it. Next slide. So this is a heat scan of auxiliary liver transplant. The green highlighted area is the native liver, the red is the new liver, and after a few months you can see the new liver is functioning, the native liver has been kind of atrophic. Next slide. Yeah, next slide. Next slide, yeah. So you see, this is another MCQ, vanishing bile duct syndrome. This is a name for chronic rejection. Like in kidney, what is the main feature of chronic rejection? Subintimal fibrosis. Acute rejection, lymphoplasmacytic infiltration. So in liver, in kidney. So in liver, what is the main feature of chronic rejection? The vanishing bile duct syndrome or ductopenia. There are other conditions of bile duct disappearance also, but gradually the bile duct simply become fibrosed and disappear. We call it vanishing bile duct syndrome, which is actually a chronic liver rejection. It is irreversible, and eventually you have to go for liver transplant again. So this is a part of surgical, part of liver transplant. Okay, one more thing. One more MCQ actually, which was asked. When we discuss indications of a contraindication indication, then we also discuss the criteria, who can give liver, donor criteria. Now, few years back, this donor criteria has been extended, and we call it extended criteria. And remember 3 points, yahi pucha jata hai ki which of the following is included or not included. So an extended donor criteria of donor, who can give liver, not recipient. 3 points, extended. Earlier, the upper age limit was 60, then 70, and now even more than 70. So an extended criteria, first is age even more than 70 is not a contraindication, right? Number 2, hepatitis B and C were contraindication, not anymore. Hepatitis C, because we do have treatment, and hepatitis B, 4 antibodies positive, you can go for transplant. So hepatitis B, 4 antibody positive, and C, who has undergone treatment, can give liver. Third point, in the past, hepatic steatosis was considered contraindication, not anymore. 30% of, up to 30% steatosis, you can take liver for transplant. So these 3 criteria are included in extended criteria, which becomes MCQ. Age more than 70 is not a contraindication anymore. Hepatitis B, C are not contraindication anymore. HIV is still a contraindication, okay? Only B and C. And hepatic steatosis up to 30% is not a contraindication. So this is the surgical part of liver transplant. Of course, I've tried to cover MCQ. It's a major topic. We cannot discuss all in 10 minutes. Now I'll come to question number 2.
All right. So before question number 2, there is a question from Shubham. Significance of finger clubbing in this patient. So significance is there is cirrhosis. If
chronicity, it will tell you about chronicity.
Cause clubbing in the patient. So cirrhosis can be a cause of clubbing, but patient initially present with acute hepatitis like picture.
Yeah, clubbing means it's chronic. Well, it's not acute, it's chronic. So that's why clubbing is very important. Now, question number 2. Last time, Dr. Arvind chose all 3 medical topics. So this time, I'm able to put one surgical topic, one question from the surgery. So this is basically a surgical question. I'll discuss this question. Question 3 again is medical. So this is a question from upper GI bleed. A 52-year-old male presented in emergency with 2 episodes of massive hepatitis. On examination, he is anxious, sweaty, and mildly dyspneic. His pulse is 110 and blood pressure is 96/70. Fully conscious and oriented, though agitated and anxious, but conscious and oriented. After starting IV line, fibroscan, Dr. Arvind can discuss later on. Let me finish this. So after establishing IV line, a thorough history was obtained. He had 1 episode of hematopoiesis 3 months back. He is a known case of chronic liver disease. He has brought his old investigation as well. Ultrasound, which was done a few months back, shows a small shrunken liver, increased echogenicity. Portal vein diameter 16 millimeter. Remember, the normal portal vein diameter is less than 13 millimeter, 13, and more than 15 is considered abnormal. More than 50 is considered abnormal, 15, more than 50. Point number one. Point number two, during inspiration, you may find slight dilatation of portal vein. Superior mesenteric splenic vein diameter does not change, but portal vein diameter may become little more. Even in normal individuals, sometimes we do get 14 or 50 millimeter size during inspiration. So portal vein diameter is more, splenomegaly and mild ascites. Next slide. So obviously, this is quite obvious, dilated portal vein and chronic liver disease. Obviously, it's a case of bulbous ascites, splenomegaly. It's a case of portal hypertension bleed. So here I'll discuss upper GI bleed. What are the differential diagnoses? I'll discuss all the points here. What should be the next step and how to manage this patient. Next slide, please. You see, the differential diagnosis are, remember this, varices is only responsible for 20% case of upper GI bleed. Varices is neither the most common cause nor the second most common cause. Most common cause of upper GI bleed is peptic ulcer. Varices are only most common cause of mortality due to upper GI bleed. Mortality, I'm repeating, not the most common cause. Why mortality is more here? Because this is venous bleed. But you see, for the hemostasis, 3 steps are important. Vasoconstriction, platelet aggregation, and clotting factor. Vasoconstriction cannot take place here because these are vein. And normal portal pressure should be less than 10 millimeter mercury. Here it is 30-40 millimeter, and vein cannot constrict, so bleeding will continue, patient will die. Best way to save the patient, bring the portal pressure down and patient, or stop the bleeding. So most common cause of mortality in portal hypertension, in hematemesis, portal hypertension. In children, most common cause of hematemesis is of course portal hypertension. In children, because ulcers we don't have, alcoholic we don't have, viral hepatitis we don't get in children. So naturally it is. But what is the most common cause of portal hypertension in children? Most common cause is EHPV, extrahepatic portal vein obstruction. So most common cause of upper GI bleed is peptic ulcer. Most common cause in children is portal hypertension. While in adult, most common cause of mortality in hematemesis is varices. Now, other rare causes are cancer, GIST, lymphoma, Mallory-White tear, urothelial. We'll discuss. Well, one more point. Investigation of choice is endoscopy. And endoscopy should be done within 24 hours of admission, right? Within 24 hours. And it has been very well proved that don't get afraid or scared of the clot getting dislodged by endoscopy. No, there are ample evidence that clot does not get dislodged. Endoscopy does not increase the risk of rebleeding. So it should be done diagnostic or therapeutic within 24 hours. Next slide. Now coming to peptic ulcer. Which vessel bleed in peptic ulcer? In duodenal ulcer, the vessel is gastroduodenal artery. In gastric ulcer, the artery is left gastric artery. Next slide. Again, two downwards arrow twice. Again, yeah. So you see, the diagram is showing 2 vessels. In duodenal ulcer, the thinner arrow is, which is the first part written behind that you have a vessel, gastroduodenal artery. So posterior duodenal ulcer, they bleed. Anterior duodenal ulcer perforate and cause perforation peritonitis. While the gastric arrow is left gastric artery. Now, I have a question for all of you, The arrow shown in the stomach, if we have an ulcer there and a bleeding from left gastric artery, based on Johnson classification of gastric ulcer, which type of ulcer is this? Most common ulcer is that incisura angularis, that's type 1 ulcer, and for that we do Billroth type 1. But I'm not talking of Johnson type 1 incisura. I'm asking the bleeding gastric ulcer, which is shown by the gastric arrow, the blue arrow, the thicker, the wider one. Which type of Johnson classification ulcer it will be? Now, next downward arrow, please. Next arrow. Next. Treatment choice for upper GI bleed is endoscopic sclerotherapy. If you have to do open surgery, then for duodenal ulcer, we ligate the vessel, we do duodenotomy, do underrunning of vessel, and do pyeloplasty. Truncal vagotomy, TV is truncal vagotomy, that is optional here. If patient stable, you can add truncal vagotomy. Patient unstable, you can just leave. Ligate the vessel, stop the bleeding, and close. Patient stable, add pyeloplasty. For gastric ulcer, the treatment is wedge resection, but you can do gastrectomies as well. Pouchet, Sendes, and Kelling-Matt Renal are the 3 gastrectomies that we do for bleeding gastric ulcer, which normally we discuss in the regular class. Next slide. Now, upper GI bleed, rare causes, and you do have MCQs. Watermelon stomach is called GAVE, gastric enteral vascular ectasia. Downward arrow, please. This is a picture of GAVE. You can see longitudinally running vessel in the antrum. It involves antrum. No, type 3 is the wrong answer, Sumi. It's not type 3. The gastric ulcer which bleeds, which is at the cardia, is which type of Johnson classification ulcer? Type 3 is a duodenal ulcer, pre-pyloric duodenal ulcer, not this one. Okay, so you can see a figure which is gay. Next, downward, next. Common in old female. It's a degenerative condition, so obviously old age. More common with chronic liver disease or chronic renal disease. You can see longitudinal vessels and they bleed off and on. They don't bleed profusely, but they bleed off and on. Treatment is usually conservative, or you can stop the bleeding by radiofrequency ablation or argon plasma ablation. Enterectomy is not the treatment of choice, but this is the surgical treatment of choice. If the bleeding continues and you have to do surgery, it should be enterectomy. It's a very old MCQ. What is the surgical treatment for GAVE? And the answer was enterectomy, but it's not treatment of choice. Well, correct, it's type 4. Kumar, you are right, it's type 4. Type 1 is incisura ulcer. Type 2 is gastric and duodenal both. Type 3 is pre-pyloric. Type 4 is the ulcer we discussed just now at the cardiac right side which bleeds. And type 5 is multiple erosion caused by NSAID. Okay, fine. Next slide. Uniform lesion is a submucosal. Rest are mucosal. While this is a submucosal artery, and this is a AV malformation, not degenerative, developmental malformation. So, developmental malformation, submucosal vessel. Normally the ulcer, there's no ulcer, only vessel. The vessel is situated on the right wall at the lesser curvature within 6 centimeters from G junction. So the moment you pass the endoscope, as you see in the diagram, from the right wall, you see a spurt, it's an artery, it's a submucosal artery. No ulcer, no varices, no cancer, no lymphoma, nothing, no lesion on the mucosa. Just a small hole and the bleeding coming from beneath the mucosa, submucosa. And you can do endoscopic coagulation. Next slide. Watermelon stomach and bulifoil lesion, you can see in the figure. Watermelon stomach, multiple longitudinal vessel in the antrum, and bulifoil is a bleeding vessel from the right. Watermelon is a degenerative condition common in old age. Bulifoil is a developmental malformation. Next slide. Another upper GI bleed is Mallory-Weiss tear, which is a barotrauma. The tear you see is a longitudinal tear on the right side, just below G junction. So, next slide. Just put this arrow, yeah. So it's a longitudinal tear just below G junction. And remember, it is only mucosa deep. Unlike Bohrheart, which is a through and through tear, it is only a partial thickness tear. So Mallory-Weiss tear is only a partial thickness tear, only mucosa deep. So there's no pain, no perforation, only bleeds. Common in pregnancy or after alcoholic binges, and it heals by itself. There's no surgical treatment, 99% no need of surgery, just supportive treatment and heals by itself. Endoscopy is the investigation of choice. Really, you can go for sclerotherapy. The bleeding vessel again is left gastric artery. So, yeah, so stepwise approach for hematemesis in portal hypertension. First, of course, is airway bleeding circulation. Then you can go for drug. Octreotide is the drug of choice, not investigation of choice, that's misprinting. It's drug of choice. Terlipressin, you see, we can give vasopressin. It reduces the portal pressure. But vasopressin is a very, very potent vasoconstrictor, so it can cause ischemic ischemia or even coronary ischemia. That's why vasopressin should always be combined with nitroglycerin. Terlipressin is most effective in bringing the portal pressure down, but due to the side effect, it has not yet been approved by FDA. So that is why the controversy. Some will say terlipressin, some will say octreotide. No, drug of choice is octreotide. Terlipressin is most effective. Terlipressin, right? And only remember octreotide, not the other analog of somatostatin, not lanreotide and other. Why not? Because those are only available for subcutaneous injection. We can give those drugs in carcinoid syndrome, but here we have to give intravenously. Only octreotide can be given intravenously, so octreotide. Then second step should be endoscopy. EVL is band ligation, endoscopy vessel ligation, which is preferred over sclerotherapy due to less side effect, but both can be done. Then if it's not relieved by EVL, you can go for second Blackmore tube. I'll show you a picture of that. Finally, tips, transjugular, intrahepatic portosystemic shunt, and then open surgery, devascularization and transaction called Segura technique. Segura is only done when you are not planning transplant within 1 year. Otherwise, you should only go for tips. Last line is important. Beta blocker, propanolol and other, or even isosamic mononitrate, these drugs are not used during active bleeding. When you have a question which drug is not given during bleeding of varices, the answer is beta blocker. They are given, but they are given after you have stopped the bleeding. They are given for prophylaxis, not during bleeding. Okay, so remember this thing. Next slide. So these are the figures of endoscopic sclerotherapy as well as band ligation. For sclerotherapy, we use ethanol amine oleate or sodium tetradosyl sulfate or polydocanol or sodium orbit, many drugs which we discuss in regular batch, in classes. But band ligation is preferred because the risk of ulcer, esophagitis, perforation is less. And for treatment, I can use either of them, but for prophylaxis, only band ligation. Sclerotherapy is not effective in prophylaxis. Next slide. This is another picture. The first one is showing the sclerotherapy. You can inject the sclerosing agent. You can inject the sclerosing in the varices or next to varices. And second is showing the band ligation. Next slide. Yeah, second Blackmore. You can see we have two balloons. Gastric balloon where we fill the air about 200 ml, and esophageal balloon where we fill the air by less than 45 millimeter mercury pressure. The third channel is for aspiration. Next slide. So you can see the second Blackmore tube, and please press the downward arrow thrice, Dr. Arvind. Yeah, 3 times, one more. Yeah. So first arrow, the in between is the gastric balloon, then esophageal, and third arrow, the lower one, is for gastric aspiration. Now here we do not have any provision of esophageal aspiration. For that, we have to put a separate tube in the esophagus. Next slide, please. So we do have a Minnesota tube. The only difference between Sinus and Minnesota is this tube has an additional channel for esophageal aspiration. Next slide. Once more, yeah. So the previous one. So these two blue arrows are showing esophageal aspiration channel, which is given in Minnesota, not in second Blackmore. Next slide. Now this is tips, transjugular intrahepatic postal-systemic shunt. You pass a guide wire from the jugular vein, reach to the liver. The guide wire will go to the portal vein. You can see the second diagram, and you place the stent between the hepatic vein and the portal vein. So you are putting a stent inside the liver, going to the jugular vein, and this is done. It has very limited indications. Most commonly, 3 main indications are: number 1, uncontrolled bleeding, variceal; number 2, uncontrolled hydrothorax or ascites; number 3, when the patient is waiting for transplant, huge varices, they can bleed any day. Then for prophylaxis, you put tips and then you wait. It will keep the portal pressure low. Contraindication are CHF, very high pulmonary hypertension, and hepatic encephalopathy, etc. Next slide. Yeah, next one. Yeah, so this is the next question. So that's about the upper GI bleed and treatment of portal hypertension bleeding. So
there is a question from Vishika Goel. Question is, how many times can endoscopic variceal ligation can
be done? EVL is not an issue about number. The problem is the sclerotherapy. Every time you inject sclerosing agent, you make the wall more fragile, more friable. So if I do too many sclerotherapies and then I go for band ligation surgery, it becomes a little difficult. EVL normally 3 to 5 bands we can apply in one sitting, and you can repeat after a few days.
All right. So this was the
question number 3. Dr. Arvind will take over.
Yeah. So moving on to the next question, slightly tough question, or you have to make a good differential diagnosis to identify the cause. So 65-year-old school teacher presented with 12-month history of epigastric discomfort and 5 kgs weight loss. So this is the presentation of the patient. Laparoscopic cholecystectomy has been carried out for multiple gallstones earlier. The discomfort continued post cholecystectomy, and his past medical history include a seronegative arthritis and a salivary gland biopsy consistent with Sjogren's syndrome. So there is some sort of the rheumatic conditions associated with the symptoms of our patient. Patient denied drinking alcohol and non-smoker, and he had become jaundiced over the preceding 3 weeks. So 12-month history of epigastric discomfort, there is a weight loss, 5 kg weight loss is there, some sort of rheumatic conditions, comorbid conditions, as well as history of jaundice over the preceding 3 weeks. So this is the clinical information available with us. On examination, patient has jaundice, wasting is present, there is no ascites, no spider nevi. So with this examination finding and the clinical history given to us, we have to think of some differential diagnosis, but first we order for the blood test. So the blood test revealed, the significant blood test revealed that plasma glucose was 190. There was no history of diabetes earlier. So this is a new onset of diabetes at the age of, you look at the age of 65-year-old. New onset of diabetes was there. ALT is 67, which is mildly elevated, but there is a gross elevation of ALP in our patient. Prothrombin time is okay. Amylase is 15. That is within the normal limits. So based on this clinical information, we did some radiological investigations, and those radiological investigation revealed ultrasound, because whenever there is a feature of a obstructive jaundice, our next step is go for a ultrasound of the abdomen. Ultrasound shows a dilated bile duct and an abnormality in the pancreatic head, which is not easily picked up by the ultrasound, but shows some sort of the abnormality. Appropriately, CT scan of the abdomen was done, and CT scan of the abdomen revealed this pancreas known as the sausage pancreas. This was followed by ERCP, and in the ERCP, 2 distal common bile duct strictures and irregular narrowing of the pancreatic duct was noted. Brushings was taken, and appropriately they were sent for the malignant cells, but it was negative for the malignancy. This is the sequence of investigations being done in our patient. So based on these investigations, it is a case of some sort of obstructive jaundice with CT abdomen showing some pathology of the pancreas. So based on this information, what are the 2 most likely possible diagnoses in our patient? Second question, what additional test will help in confirming the diagnosis in our patient? And what is the treatment of this condition? So any answers with this information given to us, that patient come with weight loss, 3 weeks history of jaundice, some sort of obstructive features were noted, CT scan shows a sausage pancreas. So this should give you some clue that you are dealing with a pancreatic pathology. So the 2 most possible diagnoses in our patient is, first always think of a CA pancreas. And secondly, we will think of a condition known as autoimmune pancreatitis. So these are the 2 possibilities that we will think of. And additional test that will help in confirming the diagnosis will be for autoimmune pancreatitis, it will be the IgG antibody, especially the IgG4. Yes, very good. Autoimmune pancreatitis. IgG4 will be a diagnostic marker, and of course, we have to go for the pancreatic tissue sample biopsy to prove our diagnosis. Now, in this patient, the possibility of autoimmune pancreatitis was made because of the CT appearance, because of the ERCP, and IgG was elevated in our patient. Hence, the diagnosis of autoimmune pancreatitis was made. And once the diagnosis of autoimmune pancreatitis is made, we will go for the appropriate treatment that we will be discussing later on. So before that, let's see what is this condition known as autoimmune pancreatitis. Yes, carcinoma pancreas, yes, it is a possibility, good. And other possibility, autoimmune pancreatitis. So this topic of autoimmune pancreatitis, some points Dr. Tewari will discuss.
You see, this is a relatively new entity, and already it has become important. It's being asked in MCQs also. Autoimmune pancreatitis is also known as IgG4 associated disease or associated systemic sclerosis. Immunoglobulin G, as we all know, is the most common. It's about 70% of all immunoglobulin. But G4 variant of IgG is only 4%. But in these cases, it's more than 40%. So IgG4 is high, leading to fibrosis of many organs, not just pancreas. So it's common relatively in old age, common in male, and most common presenting symptom is obstructive jaundice. So this is your autoimmune IgG4 related pancreatitis. Next slide. Jaundice, weight loss, and new onset diabetes. These are the three main presenting symptoms. And in Dr. Arvind's question, these were the main presenting symptoms also. Eventually it will cause recurrence and bowel absorption in diabetes and fibrosis of bile duct as well. And it's difficult to differentiate from cancer clinically because of weight loss and mass in the pancreas. This line is important. This is the last line. It responds very well to steroid therapy. Steroid is a drug of choice. You can give azathioprine, rituximab, and 6-methotrexate, all those drugs, but steroid is the main drug. Surgically, temporarily to relieve the obstruction, I can do stenting if there's a jaundice or pancreatic obstruction, but that's only temporary. Now, for diagnosis, we have a criteria called HISSOT criteria, when HISSOT is just abbreviation. H for history, I for imaging, S for serology, O for other organ involvement, and RT is response to therapy. T is written in small, all other in capital. So in histology, we have obliterative phlebitis coliform fibrosis. In imaging, now this is important, sausage-shaped pancreas clinches the diagnosis. I'll show you an image also. In serology, of course, IgG4 is elevated. Other organ like sclerosing cholangitis, Sjogren's syndrome, retroorbital fibrosis, retroorbital fibrosis, all those fibrosis you may get here, and response to therapy. So if only histology is there, diagnosis confirmed, imaging or serology both there, then confirmed, or serology, other organ involvement, or response to therapy there, then again diagnosis is confirmed. Gold standard is biopsy, but normally we don't go for biopsy. Next slide. This is a classical sausage-shaped pancreas. Next slide. These two are also sausage-shaped pancreas. Though it won't be shown as an image, but theoretically it can be very well asked. Sausage-shaped pancreas is seen in autoimmune pancreatitis. Dr. Arvind, please.
Yeah. So after making the diagnosis, as Dr. Tewari said, it is the criteria, HISSOT criteria, and the gold standard is the histology with staining for IG4, but that is uncommonly needed. So what is the treatment of this autoimmune pancreatitis? So it consists of two aspects. One is, of course, the induction of remission. So for induction, the drug of choice in the treatment is always steroids. So drug of choice is steroid, and usually we start with prednisolone in a dose of 40 milligram per day. This is the usual dose, and it gives a very excellent response. It is given for 1 month, and after 1 month, depending on the response, we will do the taper of steroids. And what will be the response? The response will be clinical response. Response will be serological response, histological response. These will be the all these things improve with the steroid use. And then on the maintenance aspect, we have to give these patients maybe low dose steroids can be given, or azathioprine can be given. While if there is refractoriness, that there is a frequent relapse with these low dose steroid or azathioprine, then we can give CD20 anterior rituximab can be given in refractory cases, in recurrent cases. This is the treatment which can be given. While steroid will not work if already atrophy has been taken place. So if there is a atrophy of the pancreas, then this treatment will not be useful. So mainly it is a medical management of the autoimmune pancreatitis, and we should have a very high clinical level of suspicion for autoimmune pancreatitis. Reason being, it is responsive to steroid therapy. So anything else in the surgical aspect, Dr. Tewari can?
No, that's it. As I said, we can do stenting. Like there's a narrowing of the CBD, by compression fibrosis, do stenting temporarily. Steroid, even diabetes responds to steroid in such cases, and fibrosis responds to steroid. So steroid will reverse jaundice and diabetes as well. Results is very good with steroid. So temporarily you can do stenting, and that's it. Surgery may be done for fibrotic mass, etc. Very rare. Surgery is not the treatment here, only medical.
It is the medical management, and it could be a MCQ like a paradoxical response. Steroid causes high sugars, hyperglycemia, but here steroid are given to treat the hyperglycemia. So it's a paradoxic thing here. That is the treatment of choice.
So if any of you have any question, please write it down. There is some lag actually when we say when you see the 50 second or 1 minute lag, so I'll wait for 1-2 minutes. Meanwhile, you can write the questions. Okay, so to utilize the time, I'll just tell you 3-4 important points about AIPG. You see, there's a forest classification, and I request all of you to remember that also. You do have question that's for ulcer, not for portal hypertension varices. So forest C is clean base, you can discharge the patient, but forest 1 and 2, A and B, you have to admit as an emergency and you have to do something. So remember, blood transfusion in peptic ulcer is done when the hemoglobin is less than 7. Endoscopy should be done within 24 hours. All these are important points. In case of atrophy, Saddam is asking what's the treatment. It's just medical treatment and supported. You have to treat malabsorption, you have to treat diabetes like a chronic pancreatitis. And there's a mild risk of cancer also. Long-term risk of cancer, you have to keep the patient on follow-up for that. Any other question? Unfortunately, I told you last time my pen is not working, so I had to make PPT. I cannot write. Dr. Arvind actually did the writing for me. Next time, I'm sure I'll have a new pen and laptop, and probably I'll be able to write something. So, any other question? Otherwise, I think that's it for today. And good night and all the best to all of you. I think I'll wait for some more time. Dr. Arvind, do you have something to contribute? Any wiser word for wise man?
All right. So it is always good to interact with the students because as a teacher we also get to learn so many things from the students. So the most important thing is, as I always say, ki ask all your doubts. No doubt is a silly doubt. It is rather silly not to ask the doubts. So that will improve your learning process.
The biggest problem is the students sometimes think that this is too basic a question to ask. They are a little sharp. Believe me, if you do not know the question, then 99% students do not know the answer. So don't feel shy. Don't be afraid. And the question from Raghav is, other organ affected in IgG4. Other organ are number 1, bile duct, Stoughton cholangitis causing jaundice. Second, thyroid, Reeder's thyroiditis. Third, parotid, Sjogren's syndrome. Fourth, retroperitoneal fibrosis. Fifth, retroorbital fibrosis. Even kidney may be involved and some lymph node may be involved. Okay? So, any other question? But jaundice is most common presentation and most commonly involved. कोई और सवाल? So it's always nice to be with Dr. Arvind. Very gentle person, polite, knowledgeable. It's good to have him here.
Thank you, sir. And it is always a learning experience from you. You have more than 20 years, I think.
No, in AIIMS itself, I've been teaching for more than 20 years. Otherwise, I have experience for 25 years.
Experience.
No, it's not. Harthi, I don't think gallbladder surgery is any relation here. Some sentences are put to confuse you. Gallbladder stones are not part of IgG4 RSS.
Okay, one question from Dr. Reddy, how it is related to post-gallbladder surgery, our clinical case. So, post-gallbladder surgery, it could be just a comorbid condition, not directly related to pancreatitis.
Exactly.
Yeah.
Thank you all of you for joining us and all the best to all of you. God bless you. Good night. Okay, Arvind?